The most widely and commonly used method for measuring creatinine levels in serum and in urine is the Joff reaction. In here, creatinine changes in alkaline medium and responds with picric acid and turns into orange. This method was presented by Max Joff 130 years ago, but is still used because of its simplicity and low cost. After the Joff method, there are also various methods that has been proposed due to the many limitations of this reaction. First is the extrinsic factors. These are the limitations for creatinine. First is the extrinsic factors, which includes age, sex, muscle mass, muscle metabolism, diet, medications, amputations, hydration, and hydration status. Um, Creatinine is reflective of the GFR under steady state condition, but has less utility in the context of decreasing kidney function. Many may not become elevated before substantial kidney function has been lost due to its renal reserve. So, in cases of acute kidney injury, it is not um, monitored early. Usually, creatinine is uh, tested for CKD patients. It is not reliably indicative of underlying pathophysiology and decreased production in sepsis and in hypervolemia, which is common in critically ill patients. For the methods, discussion will be based on the article Trend in Creatinine Determination Methods, Conventional Methods to Molecular-Based Methods. Um, First is chromatography. Chromatography is the most common and old methods of separating molecules of a mixture. The extracted analyte is examined by spectrophotometer and other detectors. One of the most important chromatographic analysis device that is used to measure or separate and identify variety of materials is the high performance liquid chromatography. It uses a mobile high pressure liquid phase to wash and displace the sample, um, placing the column along the column and separate the compound of the mixture. In one of the procedures, creatinine is separated from other species of blood serum by the cation exchange chromatography, and absorbance is measured at 234 nanometer. Um, The advances in instrumentation and column technology leads to the development of the ultra-high performance liquid chromatography. In UHPLC, to improve the efficiency of chromatographic separation, particle size of the stationary phase has been reduced to improve efficiency of chromatographic separation. And some of the advantage of these methods is that it has a very low detection limit, high sensitivity and selectivity, and sample examination in the presence of chemical disturbances. Then a liquid chromatography mass spectrophotometry is developed that has a faster analysis rate, which is less than 10 minutes compared to other chromatographic methods. The two-dimensional liquid chromatography is a technique in which two independently liquid phase separation systems are applied in the sample. It has a high resolving power, especially in dealing with complex samples. Next is the enzyme-based assays. So enzymes are protein structures that have catalytic role, and it is consumed during the reaction, and it doesn't change the reaction. Um, it may also have role of like locks and keys for a specific substrate and only affect specific molecules. In here, the creatinine acts as a substrate and the enzyme converts creatinine into measurable materials. For the limitation, first is the environmental conditions, wherein temperature affects the pH measurement and on an extremely low pH or high pH, it causes the disruption of the enzyme activities. This method, we can say that it is pH dependent. Then another limitation is the enzyme concentration, ionic strength, and concentration of the substrate. Then to define biosensors, it is a device that produces a measurable signal proportional to the concentration of the target analytes. So the following are the enzymes used in the in creatinine sensors. First is the three enzyme creatinine amidohydrolase, creatine amidinohydrolase, and sarcosine oxidase. Um, this involves the three-stage conversion of creatinine to creatinine by the enzyme CA, and creatine to sarcosine catalyzed by the enzyme creatine aminohydrolase, and lastly sarcosine to glycine by the action of sarcosine oxidase. Then the hydrogen peroxide obtained from the reaction is used by amperometric biosensors to detect creatinine. The next enzyme is creatine deaminase. Um, it is the conversion of creatinine by the action of creatinine deaminase that liberates ammonium cation. So the ammonium cation or ammonia obtained in the reaction is used as a transducer to detect creatinine concentrations using potentiometric biosensors and pH sensors. It's simple, but the endogenous ammonia have interferences with blood and particularly with urine samples. Lastly is urease, which is also used to construct potentiometric creatinine biosensors. And the disadvantage of this enzyme is this method is the complexity of the three enzyme system that reduces the sensitivity of the system itself. Next is the nanobase methods in determination of creatinine. Um, Along with the development of nanotechnology and the creation of nanoscale materials, various biosensors are also designed and developed. So, nanoparticles are classified according to their shape, size, and properties. It has a high ability of surface reaction, large surface to volume ratio, high absorption ability, and improved catalysis that makes nanoparticles be used as biosensors. It also has the ability to increase electron transfer rate between the active site and the enzyme and the electrode. Also, change in absorption and color obtained by adding creatinine to a solution containing nanoparticles is used in detecting creatinine concentrations. So the table here are some of the commonly used nanoparticles in electrochemical and colorimetric methods for creatinine determination. Next is molecular imprinting. So molecular imprinting is a technique to create template-shaped cavities in polymer matrices with predetermined selectivity and high affinity. This technique is based on the system used by enzyme and substrate recognition called the lock and key model. This technique also acts as an artificial receptor bioanalyst. This method mainly relies on the molecular identification reaction that occurs in the surrounding of the target molecule called as the template. As seen in the image, the pre-complex was first formed by the template and functional monomers. Then polymerization was completed after the cross-linking and pre-complex interaction that keep the position of the functional groups to bind the template able that will be able to produce the recognition sites. So at the end of the polymerization stage, the polymeric matrix has specific recognition sites after removing the template with suitable absorption agents. So the molecularly imprinted polymers are able to bind with the template. As an advantage, it has higher sensitivity, stability, and selective property, simple and low cost. Um, for the electrochemical methods, first, electrochemistry is a science related to electricity and chemistry that is connected by electrons. In here, it converts the analytes to measurable substances by the use of the enzymes, molecular imprints, and or nanoparticles. Some of the electrochemical methods used to make biomarkers are amperometric biosensors, the potentiometric biosensors, conductometric biosensors, and capacitive or impedometric biosensors. Okay, for the amperometric biosensor, this is based on a single or three enzyme method with the principle of measurement of the current in a chemical reaction with electrodes that results from the oxidation or reduction. And the disadvantage of this method is the complexity in the use of the three enzyme system. That means loss in system sensitivity and the use of dual sensors to separate creatine and creatinine. As an advantage, it has excellent operational stability and long storage lifetime. Interferences like ammonia is not a problem. For potentiometric biosensor, the principle is the measurement of the potential difference between the working electrode and the reference electrode in an electrochemical cell. It is based on the catalysis of creatinine by creatinine aminohydrolase at the surface of an ammonia sensing ion selective electrode. The pre-analytical removal of ammonia had been reported, which uses the thermal decomposition of alkalinized urine samples with no effect on creatinine concentration. For the advantage, it is simple and based on well-established gas sensing electrode technology. It avoids interferences with creatine. And the disadvantage are introduction of the pre-analytical step, which is the removal of the ammonia, is undesirable and adds complexity to the assay. And it has interference in blood and urine specimens. For the conductometric biosensors, um, conductometer is a device for measuring the electrical conductivity of fluids. So the conductivity does not have the capability of measuring specific ion in the sample and is used to estimate the overall content. So conductometric titration is used to determine the concentration of the ions in the sample. So it provides a large linear range and good limit of detection for determining the concentration of creatinine. For the advantages, lack of reference electrode, high compatibility, lack of light sensitivity, and ability to minimize the design of differential electrodes. Lastly is the capacitive or impedometric sensors that uses MIP or molecular imprints as dielectric. Um, The capacitance sensors are based on changes in the effective thickness of the insulating layers that results in a change in the analyte adsorption that is located at the surface of the receptor of the capacitive sensor. So the change in electrode capacitance indicates the amount of electrode capacitance resulting in the detection of creatinine concentration. So for spectroscopic and colorimetric method, it uses chemicals and nanoparticles and is the simplest method in determining creatinine. For the spectrophotometric method, the use of silver nanoparticle in picric acid yields one of the best results in the spectrophotometric method. Um, The initial color of the solution is yellow and changes into red in the presence of creatinine. The Raman spectroscopy is another type of spectroscopic technique. In the Raman spectroscopy, the strong monochromatic photons are concentrated in the sample. And the Raman scattering is an inelastic process that helps determine the composition of the sample. It shows vibrational energy levels of the molecules' chemical bonds. And the advantage is simple preparation, no need for markup methods, high sensitivity, provide information on the molecular fine structure, and non-destructive testing of samples. Next is the surface enhanced Raman scattering, which can quantify creatinine at clinically relevant levels because of its low limit of detection, which is zero point 0.1 microgram per milliliter. Um, mass spectral photometry um, is a method in which the sample is converted into gaseous ions and then the mass to charge ratio and its relevant abundance is determined. It is sensitive, rapid, and selected method for creatinine determination. Um, Next is the colorimetric methods, which is an optical technique in which color variations that occur in the sample due to the chemical reactions are measured using a spectral device like spectrophotometer. The change in color can be due to creatinine reactions with enzymes, nanoparticles, or other chemical reactions. Um, Fu et al. Presented a quick method with an integrated system, including a paper-based chip and smart detection device like a smartphone to determine serum creatinine concentrations. Although this is a practical method, it is not very accurate and still requires lots of studies. For the advantage of colorimetric, it is simple, inexpensive, with high-speed detection and good accuracy. For the chemiluminescence-based sensors, chemiluminescence happens when a molecule is stimulated by a chemical reaction. In one of the studies, creatinine reacts with hydrogen peroxide that produces a strong chemiluminescence signals. Then electrochemiluminescence is a type of chemiluminescence in which the reaction that generates light starts with an electric current and ends with it. It also uses molecular imprints to measure creatinine. Um, for the advantage, it provides accurate and ultra-sensitive analytical performance in creatinine detection, and the advantage is its high cost and restricted availability of the devices, kits, and solutions. So for point of care testing, this is available, um, but not widely used. It is a portable clinical analyzer that incorporates creatinine in the system for use in a bedside setting. It is used for quantitative determination of creatinine in whole blood. Next is Cystatin C. Discussion will be based on the article Cystatin C as a biomarker of chronic kidney disease, latest developments. Cystatin C is a 13 kilodalton cysteine proteinase inhibitor protein produced by all nucleated cells at a steady rate and is freely filtered by the kidney with near complete reabsorption and catabolism in the proximal tubule and with no significant urinary excretion. Serum cystatin C levels are much less affected by gender, age, body size and composition, and nutritional status. It has fewer non-renal determinants than serum creatinine and is requested for the following patients. Patients with estimated GFR Stage grade 3A or B with a GFR of 30 to 59 ml per minute per 1.73 mm to confirm or unconfirmed CKD. So conditions that may render serum creatinine insensitive and inaccurate for detecting CKD, and patients with significant risk factors for CKD like diabetes, hypertension, cardiovascular disease, and heart failure. Also, for patients with abnormal creatinine excretion, like in sickle cell disease, for muscular dystrophy and spina bifida. The following are the non-GFR determinants of serum creatinine and cystatin C. So creatinine is is affected by race or ethnicity other than US and European black and white, by gender, age, extremes of muscle mass and body size, high protein diet, ingesting cooked meat, creatine supplements, muscle wasting diseases, and limb amputation. On the other hand, cystatin C is affected by race or ethnicity other than US and European black and white, gender, age, disorders of the thyroid function, administration of corticosteroids, inflammation in high cell turnover states, and common genetic variants. For the clinical significance, cystatin C acts as an intrinsic marker of glomerular filtration rate. It is used for the monitoring of early renal impairment caused by chronic nephritis, diabetic nephropathy, and hypertensive nephropathy. A risk level of serum or plasma cystatin correlates closely with the GFR and therefore acts as an excellent indicator of reduced kidney function. For the standardization of the reagent, there are numerous cystatin C estimated GFR equations with different power functions that account for the variation in measured concentrations due to differences between reagents and assays. The lack of uniformity make it difficult to reproduce or share data across the institution. The International Federation of Clinical Chemistry released a reference material to be used by different manufacturers. It is the ERM DA471 IFCC. It allows manufacturers to calibrate their methods with the same reference material to facilitate standardization. But there are still substantial based bias between different manufacturers. And based on the survey by the College of American Pathologists, standardized assays resulted in a mean increase in serum cystatin C level by up to 24%. So the values here shows different variations, large variations in the values obtained from different manufacturers using the reference material issued by IFCC. So further work still needs to be done to improve manufacturers' calibration traceability to the ERM A471 reference material in order to minimize manufacturer to manufacturer error. So currently, there's no certified reference method for cystatin C. The different methods for determination of cystatin C are the following. First is the particle-supported turbidometric immunoassay, particle-supported nephelometric immunoassay, photoelectrochemical methods, fluorescence method, and the near-infrared spectrophotometry proteomics-based methods. So, in the article, development and evaluation of European-based quantitative lateral flow immunoassay for chronic kidney disease marker cystatin C, the researchers comes up with a rapid test kit for the detection of cystatin C. So, the quantitative lateral flow immunoassay detects the concentration of cystatin C in a sample with captured anti-cystatin C antibodies immobilized on a nitrocellulose membrane and then bonded with detection anti-cystatin C labeled with carboxylate modified polystyrene europium, followed by fluorescence measurement using time resolved fluorometry in 15 minutes. So the carboxylate modified polystyrene europium used to is used to label the cystatin C lateral flow immunoassay fluorescence in the sample. It is the most rapid test in detecting cystatin C levels. For the principle, it utilizes the sandwich-based lateral flow fluorescent immunoassay. So the assay buffer containing cystatin C protein was added to the sample pad, and that's the carboxylate modified polystyrene europium anti-cystatin C conjugates bind to the cystatin C protein and flow across the nitrocellulose membrane, resulting in a fluorescent band on the test line. The anti-mouse IgG was coated, which binds with the remaining conjugates with the europium binds to give the fluorescent in the control lines. The anti-cystatin C monoclonal antibody with carboxylate modified europium conjugate form a sandwich with cystatin C in the sample, and the anti-cystatin C coded in the test line. The fluorescence intensity at the test line is directly proportional to the concentration of anti-cystatin C in the sample, and the test strip data acquired from the time resolved fluorescence reader measures the peak volume of the test line and the control line. So for the result of the study, a lateral flow immunoassay based on cystatin C antibody has been developed using europium that encompasses all the disadvantages of using organic dyes as reporters. So the assay is rapid, that yields results within 15 minutes, easy to use on-site, affordable, and uses only 80 UL of sample. It provides quantitative results and can detect levels as low as 1 nanogram per ml of cystatin C. The precision assay performed to show the reproducibility of the developed kit obtained a cutoff value of 10%, which is the acceptable precision region for the anti-cystatin C quantification. The kit is stable for 1 year at 4 degrees Celsius or at 37 degrees Celsius for 1 week. The carboxylate modified polystyrene European labeled lateral flow assay method for cystatin C yields a good performance compared to the widely commercialized method. Next is the estimated glomerular filtration rate. Discussion will be based on the article Measurement and Estimation of GSR for Use in Clinical Practice, the core curriculum for 2021. So GFR is the rate at which the glomerulus filters plasma to produce an ultrafiltrate. It is used to diagnose, stage, and manage chronic kidney disease and ascertain the prognosis of CKD-related events and mortality. It is also used to determine drug dosages, and methods to determine GFR are laborious, expensive, and not broadly reliable. That makes it not appropriate as first-line diagnostic tool. The estimated glomerular filtration rate, or EGFR, is based on the concentrations of endogenous substances, particularly creatinine, appropriate for use as first-line tool, but it poses many limitations. For the measurement of GFR, the ideal filtration marker should possess the following characteristics. It should be excreted by the kidneys, not protein bound, and not secreted or reabsorbed in the tubules. Today, inulin is the only true ideal filtration rate, and inulin clearance is the gold standard for the measured GFR. Other methods are iothalamate clearance and plasma clearance of iohexol. As stated earlier, the measurement of GSR is laborious, expensive, and not broadly available. There are varying They vary according to hemodynamics, sympathetic tone, diet, time of the day, exercise, body, pregnancy, and drugs. And it cannot be directly measured in humans. So it is measured using different clearance method. And as stated earlier, the gold standard is inulin clearance. It is not also widely used due to its complexity and difficulty to maintain the solution during the procedure. For estimating GFR using serum concentration of endogenous markers, the most commonly used is creatinine and cystatin C. So creatinine is used for the initial as initial form of assessment in adults due to its affordability, simplicity, and availability worldwide, while cystatin C is less influenced by non-GFR determinants. So the following are the clinical condition in which the non-GFR determinants of selected filtration markers may be influential in reporting EGFR. So the latest creatinine equation by the CKD-EPI is expressed as a single equation wherein EGFR is equals to 142 times the standardized serum creatinine multiplied by the maximum serum creatinine by 0.9938 by 1.0112 if females. Then this one is the equation for the creatinine cystatin, the combination of creatinine and cystatin for the estimation of GFR. So the new GFR equations that incorporate creatinine and cystatin C but omit trace are more accurate and lead to smaller differences. It is noted that race is not a reliable proxy for genetic or biological differences. So EGFR does not meet the requirement for a true confirmatory test because it is greatly affected by many factors that affects the endogenous markers used. There is an absolute need for a direct measurement of GFR using a gold standard technique in patients with GFR lower than 60 ml per minute per 1.73 ml. So for convenience, most physicians with uses MDCal to calculate the eGFR of their patients using creatinine or cystatin C. The clinical significance of eGFR is that it measures the kidney's ability to filter toxins or waste from your body, and a very low number may indicate renal failure, which requires dialysis or a kidney transplant. For the normal value, it should be greater than 60 ml per minute per 1.73 ml. Next is beta-2 microglobulin. It is a polypeptide with a molecular weight of 11.6 kilodalton with a length of 99 amino acids and is a component of the major histocompatibility class 1 molecule. It is present in all nucleated cells and is needed for production of CD8 cells. It is also freely filtered by the kidney glomeruli, and almost all of it, about 99.9%, is reabsorbed and metabolized in the proximal tubule. When the renal tubules become damaged or diseased, the beta-2 microglobulin concentrations increases due to the decreased ability to reabsorb the protein. Beta-2 microglobulin appears in the urine when reabsorption is incomplete because of the proximal tubular damage as in the case of acute kidney injury. It assesses renal tubular function in renal transplant patients with elevated levels indicating organ rejection. So increased levels of beta-2 microglobulin in blood and low levels in urine indicate that the disorder is associated with glomerular dysfunction. If the beta-2 microglobulin is low in blood and high in urine, it is indicative of renal tubular damage or disease. So beta-2 microglobulin levels correlate with risk of cardiovascular disease and with the cause of death in patients with kidney disease or on dialysis. The increased concentration is found chiefly in patients suffering from lymphoproliferative diseases, chronic kidney disease including end-stage renal disease, autoimmune diseases including systemic lupus erythematosus and rheumatoid arthritis. For the methodology, it uses serum, urine, CSF, or dialysate as samples, and the methods used are immunoenzymometric assay with chemiluminescence detection and immunoturbidimetric assay. Next is Betatrace proteins. It is a low molecular weight glycoprotein and an emerging novel marker for glomerular filtration rate with an inversely proportional relationship. So elevated serum concentration of Betatrace proteins is seen in hemodialysis patients that suggests that it has a potential to be a diagnostic marker for renal disease. The plasma level is increased in patients with renal disease because of the reduced filtration in the presence of constant production. It is also less affected by sex, age, and race. Also, increased mean levels are seen in children and older adults than mid-age group. So the addition of beta-trace proteins in the estimation of EGFR with cystatin C is unnecessary, proving that beta-trace protein cannot outstand the currently used markers. So studies suggest that values obtained from the four panel markers that includes creatinine, cystatin C, beta-2 microglobulin, and beta-trace proteins is close to the values obtained from creatinine and cystatin EGFR estimation. Below is the CKD API equation for the GFR estimation from beta-trace protein and beta-2 microglobulin or the combination of both. So for your methodology, it uses immunonephelometric assay by which the reflected light rather than the absorbed light is measured that aids in reducing interferences. So the table here is a comparison of the three marker, creatinine, cystatin C, and beta-trace proteins. For the summary, renal failure is ranked as one of the most prevalent diseases with severe morbidity and mortality. Early diagnosis is relevant to reduce poor prognosis. Creatinine is still the widely used biomarker for kidney function assessment because of the method simplicity, low cost, and availability worldwide. The Jaffe reaction is still the commonly used theory utilized by different analyzers and for the development of other techniques. The advancement in the methods like the use of nanotechnology is still debatable and needs further study. And cystatin C is a more reliable biomarker compared to creatinine because it is not affected by muscle wastage, age, gender, and race. The GFR inulin clearance remains the gold standard for kidney function assessment, but due to its complexity and high cost, it is not routinely performed except for cases that needs confirmatory testing. And estimated GFR poses many interferences due to the many non-GFR determinants of the endogenous factors used in the estimation of GFR. And beta-2 microglobulin and beta-trace protein is another novel biomarker for kidney function assessment, but still requires further study for its relevance in the estimation of GFR. And lastly, the immunonephelometric and immunoturbidimetric assay is the method of choice for the determination of beta-2 microglobulin and beta-trace proteins. Mm, that ends my presentation.
Sora?